G'day, Alex. And we're back again, mate, for another episode of Prehospital Nerds. So thank you all for joining us. Today, mate, we're going to talk about something which I think a lot of pre-hospital clinicians see all the time, but in your field in emergency medicine, obviously you get to see and you get to examine a lot of these patients.
Yeah.
And that is the patient with syncope.
Syncope, yes. Is it just a simple faint or could it be something serious? It's an interesting condition because it's something we see all day, every day, and most of the time the cause is benign, but occasionally there are some serious, potentially life-threatening conditions at play, and that's the ideal emergency condition, you know, something we see every day, so we should be really good at it, and the mission and, you know, our specialty is just try and sniff out those rare, serious cases.
I think a good thing about it is we develop a bias about syncope, and we go to so many of them, and often there's not much going on with it, and so we develop this bias about being, I don't know what's the word for it, it's that it's going to be nothing again. Like the next time we go to another one, it'll be like the last one, which was nothing last time, and the one before that was nothing, but then every now and then one pops its head up and it catches us by surprise, which is good. But to start off with, mate, what can you tell me about syncope? What is the definition of syncope, mate?
We've got to have an accurate definition, and it's brief loss of consciousness with return to baseline without any intervention. I think that without any intervention is a key part, because people think, oh, it could be hypoglycemia or whatever. Hypoglycemia does not
fix when we
better.
fall to the ground.
Yeah,
no, didn't realise that.
Maybe a bit of sugar from the feet would sort of no. They need glucose to improve, you know, and all the sort of faint or syncope mimetics, most of them need a bit of intervention to get better. So, if someone's lost consciousness and then back to how they were before, then
that's syncope.
Then we call it syncope, or TLOC. What is it? Transient loss of consciousness. Would be in the literature.
Frequency? Is it something? How often? Like, you know, 1 in 100, 2 in 100. How often are we seeing this?
Oh goodness, studies that have looked at this would talk about sort of 2% of all ED attendants.
Oh right.
So, 1 in 50. So I'll do a shift later today in ED, and there'll be 100 patients, and at least two of them will come in with some story of having lost consciousness and now back to normal. So, it's very common.
Yeah, right. And so I'm assuming there's more than one cause to it. People don't just collapse for no reason. There's got to be several causes why this sort of thing happens. What are your thoughts about it?
Yeah, exactly. I think, you know, syncope is a symptom rather than a diagnosis. So you got to try and work out why they lost consciousness, and there'll be sort of 3 buckets, I guess, that you can place syncope in. It'll be the vasovagal syncope or the reflex syncope, and this is what people would sort of simply term as a faint. Then it's the orthostatic causes, where the autonomic nervous system isn't responding appropriately. Or lastly, and most concerningly, would be the cardiac causes of syncope.
Yeah, okay. What are they, mate? What are the cardiac causes of syncope?
Yeah. Well, look, they are the ones we are most worried about and try and identify. Any electrical arrhythmia, whether that's a tachy or bradyarrhythmia, can cause people to lose consciousness. But also half a dozen much rarer sort of cardiac syndromes and issues with sodium channels and stuff, Brugada or pre-excitation syndromes, or hypertrophic cardiomyopathy. We'll talk about all of them in a sec, but the other thing to say on the cardiac syncope is, of course, aortic stenosis, and that's not an electrical problem, but a mechanical problem, where the aortic valve is so stiffened and hardened, so blood is not exiting the left ventricle, not getting to the head, and they pass out. So, there would be sort of 3 buckets to try and place patients in.
Yeah, okay. No, so I want to throw something at you, mate.
Yeah.
Let's say a paramedic's turned up to somebody's house with a syncopal episode.
Yeah.
But you get there and everything looks normal.
Yeah.
And then they're all back to normal and they're saying, I'm okay, I'm fine. What should help a clinician to make a decision about whether to transport, whether to engage with a referral service, or whether to just leave them at home and not do anything?
Yeah, it's a great question, and it's pleasing to see that more and more sort of ambulance services now are getting guidelines on this and risk stratifying and trying to leave a lot of patients at home. They do not need to come to ED as a routine for any bloods or scans or anything. I think that's important to be aware that the American College of Emergency Physicians put out a position statement saying that if after history taking, physical examination and ECG, those three, if you are satisfied that this is, you know, someone who's passed out after hearing some bad news about a loved one whilst in a hot crowded room and having their bloods taken, you know, if this is the story, it's all very reassuring. They don't need any routine bloods or scans or anything. You can make the diagnosis of reflex or vasovagal syncope based on those three things alone.
That's very good. That's very interesting. And I guess that gives people in the pre-hospital environment some sort of guidance. Does that stick in Australia? Obviously, that's an American recommendation. Is that current practice in Australia?
Yeah. Certainly, when people come to ED, there's action bias. You know, we have to do something. They're here. We might as well check some things over, but it shouldn't really be done. It takes up a lot of resources, adds to the length of stay, and there's no requirement for doing so.
Yeah.
So you're allowed and encouraged to diagnose vasovagal syncope if the ECG is normal, the history is benign, and the examination is normal.
Yeah, good. That's interesting.
So,
what about? Here we go. Here's always the
Let's
what about. What if I turn up to this house and there's something tingling in my left little toe that says something's not right?
Yeah.
What are your recommendations then? If there's something in the house, the way it's set up, or the way families have communicated, or the way the patient perhaps talks or moves, or
err on the side of caution.
100%.
Bring him in. Because they've looked at this, and there's a lot of clinical decision rules out there, you know, where you take the blood pressure and the past history and whatever, and you put all this into a calculator online, and it gives you a score, what's likely. All those scoring systems, of which there's, I think last time there was a scoping review done, there was 19 of them, all of them perform no better than clinical gestalt. And if you, with 26 plus years experience, say, nah, there's something going on here, that's far more accurate than any tests we have.
Yeah, good. I think relying on your personal experience and the old gut feeling is very valuable and can certainly save you in a lot of circumstances. So erring on the side of caution is a very valuable thing. We're certainly hearing what you're saying about the clinical presentation and normal vital signs and normal ECG.
Yeah.
It's okay to leave them at home in certain situations, but if you've got that gut feeling that's telling you otherwise, then just as a means of precaution, it's probably best to transport in those circumstances.
And if you do transport them in, keep them on the monitor, because the thing you want to worry about is, have they had some sort of pause in the electrical activity, or do they go into an intermittent arrhythmia? If you could capture a strip of, they might even be going into sort of polymorphic VT for a short while. And if they had an underlying syndrome, such as Brugada, they might have a run of a VT to the point where they're not perfusing the head, they pass out, and then the electricity snaps out of that VT and into
So very good advice there. So you're transporting the syncopal patient, then keep them on the cardiac monitor all the way through to ED.
Yeah, exactly.
And that includes even moving them. That's the other thing, because we often go, oh, we're just going to take you outside. Everything's okay at the moment. We'll walk you outside. Sometimes they have a collapse on the way out. But if you've got the monitor on, we can actually capture that.
Oh, and that's the time where they could lose consciousness, you know. If the underlying cause was aortic stenosis, and the problem is when they get a bit of bounce in heart rate, is when they lose output, you want to have them monitored to say, no, they were in sinus the whole time. Well, that'll lean us more toward a mechanical cardiac cause, you know.
So one thing I want to ask is about examination. Now, pre-hospital clinicians, we do the usual things. We'll check a heart rate, we'll check a blood pressure, maybe an orthostatic blood pressure as well. We'll put on the ECG, look for any signs of arrhythmia or issues with the ECG at all. Is there anything else that you can recommend that we should be doing at scene to assess for a syncopal episode?
And then cardiac auscultation. Can I take that? I mean, that's not done often.
That's an episode in itself, talking about cardiac auscultation, because I think I could count on one hand the amount of clinicians out there that actually do listen to heart sounds. But maybe I'm proven wrong. Maybe there's a lot more that do.
If you've got a stethoscope around your neck right now, as you do when you watch podcasts, just pop the stethoscope in your hand. It should sound like this, 1, 2, 1, 2. But if you've got an ejection systolic murmur, just draw a V, and you get to hear what it is. So it should be 1, 2, 1, 2, but if you draw a diamond shape like that, it'll sound exactly like an aortic systolic murmur. And if you draw a straight line, that'll be a pansystolic murmur. We're done.
We are going to have a cardiac heart sounds podcast. That's coming. That's coming soon.
Yeah.
That'd be fantastic. I'll certainly learn a lot from that, because I don't believe I do enough cardiac heart sound auscultations.
Good. We'll pencil it in for future, but and it might seem difficult, and in the realms, but it is part. If you're going to leave them, it really needs to sort of be considered whether there were any significant murmurs. I can't pick up the subtle stuff, and the subtle stuff isn't what's going to cause them to pass out. But if you put the stethoscope over the heart, and all you can hear is whoosh, whoosh, this is...
Well, I think this actually could lead to us putting something into the show notes that we can direct people to go and listen to. Because there's nothing better than actually hearing the noises. It's all right to hear us drawing diamonds and V's on our hand, but I think if we direct them to some show notes, that'd be terrific.
Will do.
So examination, so you want to do cardiac auscultation. Is there anything else? Obviously, we're going to do a blood glucose. We're going to check the temperature.
Yeah.
We've done the ECG, blood pressure, heart rate.
Yeah.
Monitor. Nothing else. That's the main things that we need to look at this stage.
That'll tie it over. One cause for syncope could be in that orthostatic group, could be bleeding or dehydration. So sort of, a benign cause and a serious cause under the same heading, but assessing for that. So with dehydration, you could look at the skin turgor, pull it up, see how long it takes to snap back, look at the mucous membranes, how they're dry, poke out the tongue. If all of that's leaning towards dehydration and they had a big night last night, you might have your diagnosis. But also then thinking about bleeding as a potential cause, and if it's female of reproductive age, have a feel of the tummy, making sure this isn't sort of a ruptured ectopic. And that would come with all the symptoms though, so like if someone passed out due to a ruptured ectopic, they wouldn't just necessarily call with syncope.
And they wouldn't return to normal, as what you were talking about syncope is before. They would pass out and stay down.
Yeah. But the call might come through as syncope, because the call take is, got to find a card that suits, and passed out and now awake. But if they complain of abdo pain, if they're potentially pregnant, if they got a sore tummy, bring them in for making sure that there's no bleeding going on.
So in the pre-hospital environment, we have to think about management. And I'm guessing it's a very similar management pathway for all episodes of pre-hospital syncope. And that is obviously transport is probably the best management that we can do for them. The good old TLC, which I love. IV access, would you recommend that? And IV fluids?
Yeah, well, if you think the cause is dehydration, we shouldn't just give people salt water for the heck of it. But of course, if they're on the tachycardic side or borderline blood pressure, or you think they're dehydrated, sure, a bit of fluid would help. But if you go to a true sort of classic just vasovagal, they're just passed out because they don't like their blood's being taken, and that's when they passed out. The blood pressure, if you get that done early, it'll be low, but if you repeat that in a few minutes, it'll be better. So I think, if you're there as a pre-hospital provider straight away when the syncope happens, the blood pressure will be low initially. That might not mean that you got to rush to a cannula and fluids, recheck the blood pressure in a few minutes, and you'll find that it's improved. But they will. That's the sort of pre-hospital management, and it doesn't differ much from the in-hospital management until we can find a particular cause. And most of these patients, they come in and they stay a night in short stay with cardiac monitoring, see if any arrhythmias develop, and if they don't, probably have a set of normal bloods and home in the morning. And
there you go.
Oftentimes we don't find an answer.
No.
So that's maybe reassuring to know that, if they pass out in the pre-hospital setting, I've got to go to hospital and get an answer, but probably half of the people we see, again, this would be from the literature, 50% of cases we don't find an exact cause. You just make sure that it's not causing any dramas today.
Yeah, and I guess that's the thing. So we need to rule out the main issues and make sure they haven't got any arrhythmias and they haven't got profound hypotension and all the rest of it. But once we've sorted all those things out, we've made the decision to not transport, then obviously back yourselves with those decisions, I think is probably one of the important things.
Yeah.
Mate, thanks again. Beautiful little pearls. Is there anything further you want to add to it at all?
Well, let's talk about ECGs. Can we?
Tell me,
ECGs in syncope. So, I think, we're all pretty experienced at looking for STEMI or ischemia and looking for blocks. If you go to someone and they're in 2nd or 3rd degree heart block, missing a lot of beats, you know that they need transport and a pacemaker eventually. If they're in 3rd degree heart block and passing out, they'll get a pacemaker. But then there is sort of half a dozen syndromes which are worth being aware of. They're rare, but when you pick them up, you sort of save a life. So there's a lot of mnemonics out there for how to remember this. Life in the fast lane we'll talk about.
That's fantastic.
Quick,
my go-to.
Quick can Brad walk home or something. And other people have just done it sort of alphabetically. There's a thing on A and B and C and D. Sometimes I struggle to remember those mnemonics. I think it makes sense just to look at the ECG from left to right. So look at the P wave. Is that normal shape or very enlarged? And you're thinking of atrial enlargement. That could be a cause. Then look at the PR interval. If that's prolonged or missing a few beats, you're thinking of any other blocks. And then moving into the QRS, look for that delta wave. At the end of the PR interval, we want a sharp start to the QRS, but if that sort of drags out, there might be a degree of pre-excitation, which if they've got pre-excitation, they might go into a non-perfusing ventricular rhythm for a while, and then by the grace of God, they're back to normal rhythm.
Yeah.
And that'll, of course, come through as a syncope and now back to normal. But if you go to someone with syncope and you see that little delta wave, you ought to worry.
Yeah.
And
mate, we could talk for hours about ECGs, I reckon, and that's another podcast that we have to do.
Let's do it.
Other things, other arrhythmias that you're sort of suspecting, obviously the pre-excitation. Bundle branch blocks, are they much of a concern?
They have gone back and forth, haven't they? For instance, right bundle branch block, people used to think was a problem. And then they did all these screening ECGs on young, fit guys that were about to go into the military. And they saw all these right bundle branch blocks and, we'll have to call it a normal variant. But now, again, the thinking is that it probably is a bit pathological to have a right bundle branch block. A right or left bundle branch block in and of itself shouldn't really cause syncope, and oftentimes it's pre-existing. But looking at the QRS, you also want to look for sort of very sharp, deep Q waves, which could be these dagger Q waves. I could talk about this all day, mate, but HOCM or hypertrophic cardiomyopathy, I mean, that's the commonest sort of lethal cardiac arrhythmia in young people. And the problem is, that they are the ones that sort of die during exercise. You see them on the field or whatever, running and then drop dead. So if you come across this, luckily they just had syncope, not cardiac arrest. You see deep dagger Q waves. They get beta blockers. Strong advice: don't exercise, don't do anything until you've had an echo.
Yeah, right. Interesting.
So, the syncope, the fact that it's so common and occasionally serious, that's the ultimate mix.
Yeah, and I can think there's a lot of patients that I've been to with syncope over the years, and for clinicians, pre-hospital clinicians, I think stick to your basics. Don't vary from your basics. Do your routine each and every time, and we talk about clinical approach and how important it is. If you've got a systematic approach that you do to each and every single patient, you won't miss things.
No.
Rely on your gut instinct as well. If there's something that's not quite right for you, take them off for further investigation.
That's right. Do we have time? Can I show you a model of
Yeah,
syncope?
by all means, mate. By all means. What
Let's
do you got?
go.
What do you got in store for us now?
So,
I hate to see where this is going.
here we go. This is just a boost tablet, right? But this is sort of a model, I guess, for the whole cardiovascular system. So up here is the head. Mm-hmm. This is your head.
I'm going with it. Yep.
And in here is fluid, the blood. Now to get perfusion to the head to not pass out, the vessels have nerves on them. This is the autonomic nervous system. Squeezing a bit here, holding the vessels in place. So that blood is in the head, and not passing out.
Yep.
Now just looking at this, and the blood goes up to the head with every beat, like so, bang, bang. The 3 causes of syncope would be, so meaning, syncope is that, there's not enough of this stuff getting up to here. What are the 3 causes? Either there's not enough fluid in here, that would be the orthostatic causes, which could be bleeding or dehydration. Or also with the orthostatic stuff is that the autonomic nervous system is not responding. So you'll see people, they lay down. When you lay down, there's a bit of blood in the head. But when you stand up, when you and I stand up at the moment, what happens in you and me at the moment, the autonomic nervous system kicks in, the vessels get squeezed and blood gets to the head.
Yep.
But if you've got Parkinson's or diabetic neuropathy or on a lot of medications that interfere with the autonomic nervous system, it's not able to squeeze the blood up.
Yep.
The blood stays there and they pass out.
Again.
So, and then obviously cardiac, if the pump that does squeeze the blood up here every beat
is not
isn't doing its thing, eventually you're going to pass out.
Wonderful. Makes sense, mate. You're not going to drink that. I don't know where that's come from.
Cheers to that. Good.
Very good. Well, anything further to add, or that's it, mate?
I think that's it. Be encouraged and empowered to leave them at home if there's nothing of concern in accordance with your own
service
practice
recommendations
guidelines.
And guidelines, absolutely.
Yeah. A cardiac auscultation would be very good, which we'll do an episode in the future.
I wonder, certainly I know within Victorian university settings, teaching cardiac auscultation is probably not done an awful lot.
No.
And I'd be very interested to see what happens throughout the rest of the world, whether it is something that paramedics are taught an awful lot of, because I feel it's not something, and we can talk about percussion, chest auscultation and percussion.
Yeah.
Percussion is not something that's taught very well at universities for paramedics. So,
true.
Maybe there's an opportunity for universities and pre-hospital courses to increase the amount of clinical assessment skills.
Yeah.
We can do more podcasts on clinical assessment skills later as well. So,
in the interim, we'll fill the gap.
Oh, 100%.
Yeah.
Let's do it. Maybe we could do that on the clinical night we're having.
Yeah.
There's a thought. Anyway,
Sign
we
up.
digress.
Yeah.
Thanks very much, everybody, for joining us again, and we look forward to seeing you on the next episode. Thank you.
Thanks.